And now I'm happy to proceed with introducing the next speaker, Emma Olsson, who is a pediatric and neonatal nurse working at the neonatal intensive care unit in Örebro, but she's also a PhD and senior lecturer at the School of Health Sciences at Örebro University. And she will talk about tools for evaluation of stress, pain, and well-being in infants.
Yes, my name is Emma Olsson, and I want to start with saying thank you to the organizing committee for inviting me here to speak today. And I will be talking about tools for evaluation of stress, pain, and well-being. I have no videos, sorry, but please stay awake. I have no disclosures, I have no $1 million funding I have to disclose, but I can disclose that I have been working with NICU care for quite some time now. My main research focus is on pain assessment, pain management, as well as trying to include parents. I divide my time between working as a senior lecturer at Örebro University, as well as working as a nurse at the NICU in Örebro. I'm also part of the PEARL research group that Mats Eriksson are leading. Also a member of the Cochrane Collaboration. I've done a few Cochrane reviews. And I'm also a board member of the Swedish Pediatric Pain Society. When I'm not here talking about research, you can find me in the nearest CrossFit box. My plans for the next half hour is this. How do the infants at the NICU express pain? Different ways we can assess their pain. Of course, a little bit about pain scales. Are they any good? And what do the staff think about assessing pain? And also, it seems like the theme of the day, parents, can they assess their infant's pain? I think we all can agree after this day that pain and stress is negative for the infants at the NICU. We need to assess their pain in order to achieve an optimal pain and stress management. And we want to find the infants that are in pain and also minimize the risk both of under and over treatment. This is a typical NICU patient, and as you all probably know, self-report is considered the gold standard when assessing pain. It doesn't matter how many times I ask this question. I'll ask this patient, how is your pain today? He or she will obviously not respond. And the International Association for the Study of Pain concludes in their definition of pain that verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or non-human animal experiences pain. So just because our infants can't vocalize their pain, they need to have their pain assessed. And they also have the same right to an adequate pain relief as older children and adults. I often get the question about stress. How do we know that the infant is in pain? Can it be it's just stressed? Well, often we use these words together, stress and pain, or pain and stress. And what we can say is that pain is always stressful, but stress doesn't always need to be painful. But they both give the same sort of symptoms in the infant. And we should do our best to avoid both stress and pain, because they are both bad for the infant. And if we move on to how our infants express pain, this is one way of categorizing different indicators of pain. And I thought we would go through them. Starting with physiological indicators, and here are some of those. Heart rate can go both up and down, as you know. Respiratory rate is often increased when exposed to pain, but with the preterm infants, you know that they can just as well stop breathing. That's also a sign of pain. Blood pressure is often increased, with especially bad for the extremely preterm infants with the sensitive blood vessels. Oxygen saturation often goes down. Cortisol, that is a stress hormone, often is increased during pain. But the problem with this is that these variables can also change due to other things than pain. If you have an infant that is very warm, for example, he or she will often react with an increase in both heart rate and respiratory rate. If you have an infant that has respiratory issues, of course, this will also maybe increase the respiratory rate without it being caused by pain, for example. And what I said, prematurity problems, you know that the preterm infants, they can have variables going all over the place just by being immature and preterm. So that's something we need to be aware of. If we move on to the behavioral indicators, here are some of those. And facial expression has shown to be the most valid behavioral sign of pain. Cry might be the more mature infants, perhaps the more older infant that can produce a cry. Body movement, as we've already talked about today, the splayed fingers you see here in the picture is a sign of pain. Fussiness consolability is in a few pain scales as an indicator for pain. And alertness and sleep, you might know that infants that are asleep have a reduced ability to show behavioral signs of pain. So that's also something we need to be aware of. And also these variables have their challenges. The most preterm infants, they lack the ability to show strong behavioral actions due to pain. And also with the preterm infants, they're exposed to a lot of pain. They react more forcibly in the beginning of the care, and as time goes by, they will have almost like a shutdown reaction towards pain. Mechanical ventilation, if you have a tube going through the vocal cords, of course you can't produce a cry. And the tube will also often make it more difficult to inspect the infant's face. And of course, if you treat the infants with like sedatives, you will have also reduced ability to show signs of pain. And the neurophysiological indicators of pain, here are some of those. And I thought that we would go through them a bit if you're not familiar with them. And these guys also have the challenges. As of now, it's only useful in the research setting when you have a very controlled environment and a control context. So that's, I just bring out all the challenges here. And if we talk a little bit about NIRS, near-infrared spectroscopy, it can look like the machine here on the picture. Then you have optodes that you fasten on the infant, and you send in near-infrared light into the tissue. Here you see, going down, and then it comes back on the other end of the optode, and you will measure the local blood volume under the optode. And an activation will lead to an increase in the oxygenated hemoglobin, which is, if you put this optode over the somatosensory cortex, by this you can assess pain. It will be a proxy for pain. And there are quite a few studies that have used this method as pain assessment. Also with NIRS, you have possible challenges where movement and environmental factors can interfere with your assessment. I have used this in a project, and it's enough if you put a bright light on the optode, you will have variables going all over the place. And also, since this is a measure of the blood circulation, if you have a systemic change in the blood circulation, you will also have a change in the NIRS readings. And we also have some problems with different researchers using different placements of the optodes, as well as using different variables, making it difficult to compare studies with each other. Skin conductance, it's been mentioned already today. That's when you put electrodes on the infant's feet, as you see in the picture on the top. And it measures emotional arousal. When you're exposed to stress or pain, you will have an increase in the sweating on both the hands and the feet. And this increased sweating will lead to an increase in the skin conductance. And this will be an indirect measure of the sympathetic nervous system activity. And this is also the same technique that is used in lie detectors. The good thing with this is that it's not affected by hemodynamics or cardiorespiratory changes, such as NIRS can be. But also with this technique, we have potential challenges. If you look at the studies that have used NIRS, galvanic skin response, not all of them are reporting missing data, and the ones they do have quite a lot of missing data due to different technical issues. Also here, as same as with the NIRS, you have a problem with the researchers using different variables from the skin conductance, making it different to compare studies. And also here you could have problems with movement artifacts, that the infant won't lie still because they're not machines. EEG, I think you all are aware of what that is, measures the cortical activity. This is, of course, a very complex technology. It's difficult. It's not up to anyone to just hook the infants up with a lot of electrodes and think that you understand the curves coming out on the other end. So it's complex. But it seems to be a more direct measure of pain when you compare, for example, with NIRS. Here's an example of a study that was published recently that used EEG as the outcome measure. And as you can see, there are a lot of missing data here due to technical problems. They wanted 54 infants in each group and had to exclude 15 and 11 respectively. And this is just a messy reality we are dealing with. The infants won't lie still where we lay them, and the technology will be a problem sometime. So moving on to pain scales. There are a lot of neonatal pain scales, as you probably know, over 40. And these are the most commonly used pain scales according to Professor Camilleo's article from last year. There are more pain scales for procedural pain. It's much easier to do research when you know you are exposing the infant to something painful. But there are, of course, also scales for postoperative pain as well as prolonged pain. And then you might wonder, what do you need for a good pain scale? And I borrowed this from also Marsha Camilleo as well as Mats Eriksson and Brittany Benoit. I think they did a good overview of this. You want a scale that can detect all painful situations, meaning it has high sensitivity. You want a scale that can discriminate pain from non-pain, making it having high specificity. You also want a pain that can measure the type of pain you are supposed to measure, meaning it has good validity. You also want a scale that gives the same results if you use it several times or if you are several users using the scale. That means it has good reliability. And you also want a scale that can establish if a pain-relieving treatment was given. If you have a scale that gives an infant a high score and then you treat the infant with pain relief, you would suggest that you get a lower score, meaning it has good responsiveness. But this is not enough. You also, me coming from a clinical side of it, you need a scale to be feasible, because you don't have a lot of time doing pain assessments. You want a scale that is easy to use, clinically useful. So that's also one thing to have in mind. Norwegian colleague Randi Dovland Andersen looked at what type of pain scales are used in Sweden and in Norway. And as you can see, the blue bars are the scales we used mostly in Sweden, different versions of Alps Neo. While in Norway, Edin was most common. This was from 2017, I should add. And if we look out into the world, this is a brand new study of a global cross-sectional survey of both pain assessment and pain management. And this was a survey that was sent out, and almost 1,000 people replied. And as you can see out in the world, the PIP or PIP-R is the most commonly used scale, followed by NPAS and NIPS. And I thought we would look a little bit closer to PIP-R. It's been shown by Martina, but you can see it again. This is also the scale that has most research done to it, both validity and reliability. It's mostly a procedural scale. And what you do is that you, before the procedure, you note the infant's heart rate as well as oxygen saturation. And you also note how old the infants are, and also if the infant is awake or asleep. And then you do your painful procedure, and you look at what happens with the heart rate and what happens with the oxygen saturation. And you also look at these three facial features: brow bulge, eye squeeze, and nasolabial furrow. And if you have points on this upper part, you will also receive these kind of bonus points for being very preterm or for being asleep. Because as I said in the beginning, infants that are very preterm and infants that are asleep will have a reduced ability to show signs of pain. I've used this in research. I think it works fairly good. And then I have the luxury of videotaping the infant's face and videotaping the infant's oxygen and heart rate values. So then I can do the pain assessment afterwards, playing back, playing forward, etc. I would think, and it's just my personal opinion, that it might be difficult to use this in real time in the clinic, because there are a lot of variables you need to monitor. ALPS-NEO was a scale that was mostly used in Sweden, and this is mainly a scale for prolonged pain. And you look at these five parameters: facial expression, breathing pattern, tone of extremities, hand-foot activity, and level of activity. And then you will get a score from 0 to 2. And the higher score is a higher indication of a rated pain. I use this in the clinic, and I think it works fairly good. It's never easy to assess neonatal pain. I think you can agree on that if you work at the NICU. But this is, it doesn't take a lot of time. And then you might wonder what scales are used in research. I was a part of this systematic review that looked into this. We included 352 studies. And what we saw was that the same 8 scales were used in almost all the studies. And you have 6 of them mentioned here. And PIP and PIP-R was the most commonly used scale. What we also saw was that very few studies were on ongoing pain or postoperative pain. As I said, it's easier to do research for procedural pain when you know you are exposing the infant to pain. There was also very few on the extremely preterm infants. And sadly, 15.6% of the studies were actually using the wrong type of scale for either type of pain or type of population, which is very sad if we as researchers can't even use the correct scale. And only 1/3 of the studies actually had a low risk of bias. And this could be due to, for example, lack of blinding, incomplete outcome data, or selective reporting. And this isn't a very good grade for us as researchers. This is another systematic review of both neonatal and pediatric pain scales. And as you can see here, not even half of them had been adequately testing, according to the author. And this author, Giordano, also did this very attractive table, I think, where he is showing both validity and reliability and the undergroups for these. And I've chosen to have one study with ALPS-NEO on the top, and then you have 3 with PIP-R and 2 with NPAS. And what you want to see is a lot of these blue boxes, meaning that the authors, researchers have used statistically testing these different variables. What you don't want to see is a lot of these red boxes with the white crosses, because that means they didn't test it. And what we can see is quite a lot of these red squares. especially on the validity side. So something we need to work with. I'm also part of this Cochrane review that actually is a methodological Cochrane, and we are with this review evaluating the quality of the neonatal pain scales according to the COSMIN guidelines. And this review isn't published yet, we're still finalizing it. But we will conclude that with the criteria from the COSMIN guideline, no neonatal pain scale is considered of the highest quality. And what we often see is that in researchers they take one scale and then they compare it with the other scale, and if they both give the sort of same results, you will conclude that the scale is valid. But it takes much more than this to thoroughly provide evidence on a scale's validity. And of course, it's difficult because we will never have self-report as the gold standard. So I get it, it's very difficult, but something we need to work with. And the staff that are doing pain assessments in their daily job, what do they say about this? I did, together with Ylva Hellström-Westas in Uppsala and Maria Gradin, a questionnaire that we sent out to physicians and nurses in 7 different NICUs. We also here saw that ALPS-NEO was the most commonly used scale. What we also saw was that a lot of the staff didn't think they had enough knowledge of pain assessment, which is the problem. There was also clearly a frustration in the open questions from the nurses due to the lack of interventions after pain assessment. They wrote very much about this, explaining it as you do pain assessments, and when you get high scores, you get to the physician and say, this infant is in pain, we need to give it something, and the physician comes in, look at the infant, and thinks, I don't think this is pain. So that was a frustration from the nurses, and also something I think we should look into a little bit closer. Here's just a quote as an example. I, as a nurse, have to fight a lot so the infant can get pain treatment. And if I manage this for the patient, he or she will often only receive it during my shift. Here is from the previous study I talked about, where 1,000 people replied to a questionnaire. And you see here the first question on the slide is who is doing the pain assessment? And this author also divided the replies from sociodemographic index, and you see here high sociodemographic index countries, middle high, middle, low middle. And what we see is that in the high sociodemographic index, there is more common that the nurse is doing the pain assessment, while in the low and low middle, it's more common that the physicians, the doctors, do the pain assessment. And in the bottom part, you see they also asked about medical staff paying attention to scales when measured by nurses, which is a little common to the questions we had in our Swedish questionnaire. And it seems that more of the doctors in the countries with a high sociodemographic index are interested in the pain scores. But as you can see, the interest form, that they aren't even very great in these countries either. And the parents, we talked a lot about parents today, and I think they are important even with pain assessment. But it doesn't seem that we are involving them as much in pain assessment as we probably should. Because as Mats said previously, parents want to be involved both in assessing pain and treating pain. And studies have shown that parents can recognize their infant's pain, but they tend to underestimate the pain compared to when healthcare staff do the assessment. So parents need guidance on how to interpret an infant's pain and how to do a pain assessment, which isn't that strange. Here is a model from a study from a Finnish researcher who interviewed parents about interprofessional collaboration when it comes to neonatal pain. And she found that the parents' experiences could be organized into these 3 themes. Under partnership, the parents expressed that they were not particularly involved in pain management, but they felt valued when they were encouraged by the staff. Under cooperation, and open and honest communication was important for the parents, and they trusted the professional knowledge of the staff. Under coordination, the parents expressed the need for guidance on pain assessment and pain management, and when staff included the parents in discussions, it made them feel both supported and empowered. So I think this figure is not only attractive for the eye, but visualizes the importance of the responsibility we have as healthcare personnel when it comes to involving parents. We involve them in everything else. We want them to change the diaper, we want them to feed their infant, we want them to sit with them. And we should also involve them in pain management and pain assessment. So I've spent some time saying that pain scales aren't that good. Should we still use them? Yes, I think we should still use them. We are in agreement that pain assessment is the foundation of an optimal and safe pain treatment. And they also have added value, because if you have a pain scale at the unit, you will document more about pain, which is a win. And if you document more about pain, you will treat pain better, which is also a win. And we also know that infants whose procedures are pain assessed will more often also receive pain management. And then we can ask the research, how should we use pain scales? And I came up with these suggestions based on what the research say. We should use a multidimensional scale. For example, the PIP-R that uses both behavioral as well as physiological indicators. That seems to be good. Even if no scale is the perfect scale as of right now, we should use a scale that has most validation and most reliability testing done to it. And of course, use a scale that is developed for the type of pain and the type of infant you have in front of you. And also, research has shown that if you have a lot of different pain scales at the unit, you will get confused. You're unsure of which scale to use when. So use a limited number of pain scales at the unit. And also, it seems obvious, but we should also be trained in how to assess pain. We're trained in how to take care of an infant on a ventilator. We're trained on how to assess an infant in other ways. We should also be trained in how to assess their pain to do a good job. And I also think it's important that it doesn't get to be like the nurses is on one side and the physicians is on another side. We need to talk about pain assessment at our units. We need to have interprofessional collaboration and discussions about this, because we need to be unified to provide the best care we can give these infants and their families. So, yeah, that was all I had to say. And please reach out if you want to discuss this further.
Thank you very much for a very informative talk. Are there any questions or comments for Emma? No? As a Swede, I think I'm a bit proud when I see all these Swedish names. And I wonder if there are any statistics or studies showing per capita how many papers we produce on pain and so on.
I have a slide when I talk to the pediatric nurses on the Swedish being quite good at doing research on neonatal pain. So we are good for a small country.
Yeah, I see the collaboration spreading over the country. That's very nice to see. Well, congratulations to your studies, and we move on because we're late. Thank you so much. And I'm happy to, yeah, we could give you one more applause. I'm happy to introduce the last.